Good day, everybody. Today we'll be talking about substance-induced psychotic disorder. So, the topics that we'll be covering are first we'll talk a little bit about the diagnostic entities, then we'll talk about the epidemiology, then the clinical differences between various types, course and prognosis, differential diagnosis. We'll talk a little bit about the treatment, and we'll also consider substance-specific disorders like specific psychotic disorders in relation to alcohol, cannabis, cocaine, and hallucinogens. So coming to the history a little bit, in DSM-1, it was basically called acute brain syndrome, chronic brain syndrome, and acute brains syndrome. Uh, this was used to refer the psychotic disorder and usually due to secondary cause. In DSM-2, alcoholic hallucinosis and alcohol paranoid state was included. So it was formally recognized during around that time that alcohol is causing a paranoid state. When DSM-4 and DSM-4 TR was released, then the proper nomenclature, substance-induced psychotic disorders, in the section on schizophrenia and other psychotic disorders was introduced. And there were specifiers for the onset during intoxication and onset during withdrawal. So where we currently stand is in DSM-5 and DSM-5 TR, although the name of the disorder was changed to substance/medication-induced psychotic disorder. So the current diagnostic entities, basically the DSM-5 and the ICD-10, they categorize or classify the substance-induced psychosis as a presence of one or both symptoms, that is one delusions, and the second hallucination. The criteria B states that there is evidence from the history, physical examination, or laboratory findings that either one or two, the symptoms and criteria A developed during or within a month of substance intoxication or withdrawal, or the medication used is etiologically related to the disorder. There are other specifiers also that the disturbance is not more accounted for by a psychotic disorder that is not substance induced. So it is necessarily a diagnosis of exclusion. You are excluding the other diagnosis, and then this is what remains. The disturbance does not occur exclusively during delirium. This becomes very important because many a times physicians tend to mistake the person's delirious state with psychotic episode. Now, the final criteria here is that the disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of function. So now this is mental and behavioral disorders due to psychotic substance use, F1X.5 psychotic disorder. So this is from the ICD-10. It says that it is a cluster of psychotic phenomena that occur immediately or during after the psychoactive substance use, characterized by vivid hallucinations, misidentifications, or delusions or ideas of reference, the psychomotor excitement, which might range from excitement to stupor, an abnormal affect, which may range from intense fear to ecstasy. The sensorium usually is clear. So in delirium, the key feature will be that the sensorium will not be clear. There will be disorientation to time, place, and person. There might be clouding of consciousness. There might be hyperarousal, as we discussed in the previous lecture. So here, those things are not there. And the duration criteria here in the ICD is mentioned to be it resolves at least partially within 1 month and fully within 6 months, provided that the person stops using the substances. So in the guidelines, the keywords to focus are a psychotic disorder occurring during or immediately after drug use. So usually within 48 hours. So that should be recorded here, provided that it is not a manifestation of drug withdrawal state. So again, even the ICD and DSM make a point of conveying that delirium is a distinct entity and psychotic disorder should be considered separately. The diagnosis of psychotic disorder should not be made merely on the basis of perceptual distortions or hallucinatory experiences when the substances involved are having primary hallucinogenic effect. For example, mescaline or LSD, if you consider those substances that are primarily going to induce hallucination, then only presence of hallucination should not amount to a psychotic disorder. They might just be effects of the substance. In such cases, you have to look for confusional state, a possible diagnosis of acute intoxication, which should be considered first. Now, coming to the epidemiology. So, in general, the data regarding substance-induced psychotic disorder as an entity is scarce. In the Lundberg study, prevalence of the substance-induced psychotic disorders was 0.59% over the lifetime of an individual and about 6 times more common among males than females. In a 2005 New York City Hospital Emergency Department study, 44% were diagnosed as cases of substance-induced psychotic disorder. When these patients were re-evaluated a year later, 25% of these cases, which were initially diagnosed as substance-induced, were re-diagnosed as cases of psychotic disorders not related to substances. So here the point to note is that sometimes a primary disorder might be masked due to substance or might be aggravated, and a diagnosis of substance-induced might be made, which has to be re-evaluated later in the absence of the substance. So data related to individual substances will be mentioned in the concern section when we discuss about the individual substance. Now, coming to clinical differences between primary and substance-induced psychotic disorder, right? So a primary disorder will have certain features which will help us distinguish when compared to substance-induced disorder. So Mori and colleagues basically did a study, and they concluded that patients with primary psychosis had an earlier age of onset compared to ones with drug-induced psychosis. It also showed that baseline higher scores in an item called unusual content of thought was present when rated with the scale BPRS. So if somebody is going to have a primary psychotic disorder, usually it will start early, and the unusual content of thought would be higher score. Whereas in substance-induced, these features are not prominently there. So Wilson et al. Also did a study. Subjects affected by drug-induced psychosis showed a weaker family history of psychotic disorders, a greater degree of insight, fewer positive and negative symptoms, more depressive symptoms, and more anxiety. So the psychotic disorder which was induced by substance had different characteristics than a primary let's say a primary schizophrenic. So now coming to course and prognosis of substance-induced disorders. It is generally favorable. It typically remits after removal of the offending agent. However, there have been reports of continuing psychotic symptoms for weeks or months after stopping stimulants, cocaine, or phenylcycline. Treatments with antipsychotic medications may be needed in cases of severe medication-induced psychotic disorder associated with agitation or suicidal or homicidal ideation, or any other sort of life-threatening or life-harming behavior. Now, coming to the last point here, hospitalization may be needed for safety of the patient in some of these cases. So patients with substance-induced psychosis showed similar positive symptom severity. One second. And more severely disturbed behavior at admission compared to patients with primarily psychotic disorder. So both the symptoms came down. Abatement was faster in the induced category. So that was the point. Subjects who presented with psychotic symptoms after substance abuse seem to have a high risk of development of a primary psychotic illness. So recent studies provide evidence that the above-mentioned group of subjects is more likely to develop a schizophrenia spectrum disorder or a primary psychotic disorder. So this is the second thing that we need to keep in mind here, that the person who actually has a psychotic substance-induced psychosis might be more prone to developing a primary psychotic state. So Starzer et al. Stated that strong association between substance-induced psychosis and development of either bipolar or schizophrenia spectrum disorder is present. Young age was associated with higher risk of converting to schizophrenia, and finally, self-harm episode after substance-induced psychosis seem to be significantly linked to a higher risk of converting to either schizophrenia or bipolar disorder. Now, coming to the differential diagnosis. The first one is rather intuitive. So a major differential diagnosis is between substance medication-induced psychosis is the independent psychotic disorder that is not substance-induced. So here, again, we discussed a few features in the previous slides. So those have to be kept in mind. Now, the other things that can be kept in mind are the temporal order of symptom onset, the course of psychotic symptoms, the past history. All of these become important considerations. If the psychotic symptoms preceded the onset of substance medication use, or symptoms persist for a substantial period of time, that is about for 1 month, after the acute withdrawal or severe intoxication, then the psychotic symptoms are more likely to be related to primary disorder rather than substance. Now, coming to specific features here, such as atypical age of onset, first presence of delusions in a person older than 35 years, or without a known primary history of known primary psychotic disorder, or the nature of symptoms also may provide some guidance in differentiating substance medication-induced psychotic disorder from primary psychotic disorder. Certain types of psychotic symptoms and accompanying symptoms are more common with certain substances. For example, cocaine use is associated with a phenomena called cocaine bugs. Persecutory delusions, as mentioned as early as DSM-2, were found to be associated with alcohol, with labile mood also. Labile mood is also seen in cannabis. Labile mood and persecutory delusions are also seen in cannabis-induced psychotic disorder. Auditory hallucinations and alcohol-induced psychotic disorders are also very common. Usually they are derogatory, so that is a source of distress for the patient. Assessment of cognitive and mood symptoms is vital for differential diagnosis. So here again, the other thing that can, if the primary psychotic disorder is schizophrenic, then you have to evaluate on the lines of, let's say, negative features or unusual thought content, those things. If you suspect a mood disorder, then mood fluctuations, variations in mood, premorbid personality, all might be indicators. And obviously, one has to rule out delirium, because delirium again is an organic condition which needs a specific treatment. The DSM-5 clearly states that if the individual recognizes that the hallucinations are the result of substance or medication and does not act on them, the experiences, then these experiences should not count towards the diagnosis of substance or medication-induced psychosis. Prolonged use of hallucinogens is sometimes associated with recurrent hallucinations long after stopping the use of these drugs. Reality testing remains intact in these cases, and the person is aware, and these experiences are related to drug effects. Such flashbacks should be diagnosed as hallucinogen persisting perception disorder and not psychotic disorder. Again, the insight becomes the key here. A difficult differential is to separate the effects of medication and the effects of underlying medical or mental disorder for which the medication is prescribed. Again, clinical history, course of illness, nature, and course of treatment may provide clues here. If the disturbance is deemed to be related to both medical condition and substance medication use, both diagnoses should be made. Psychotic disorder due to systemic lupus erythematosus or steroid-induced psychotic disorders come to mind. Now, coming to the next section, that are the substance-specific considerations. So, many substances, when used medically or recreationally, are known to cause or exacerbate or increase the likelihood of psychosis. So, there is increased number and variety of new psychoactive drugs. In time, more and more potent substances have been created and spread in their use, with more several effects and consequences for recent users in comparison to the past. In the next section, specific substances known to cause psychotic symptoms and the characteristic symptoms produced by such substances will be reviewed. So now coming to the first and the most commonly seen psychotic disorder. Based on the sheer numbers or the sheer magnitude of the incidence and prevalence, alcohol use. The association between alcohol use and psychosis was documented as early as 1846. Kraepelin and other authors also reported a distinct psychotic syndrome associated with alcoholism that is differed from delirium tremens, which would be delirium in alcohol withdrawal. Wernicke's encephalopathy, Korsakoff psychosis, and alcohol-induced dementia. So it was recognized to be an entity which was not all these things. Now coming to the epidemiology. The lifetime risk for alcohol dependence is 10 to 15% in males, so it is a relatively high number. It is 3 to 5% in females, and only 2 to 3% of such patients end up having Psychotic. So it is estimated that AIPD patients, uh, that is alcohol-induced psychotic disorder patients, represent a minority, that is 33.1% of the group of patients experiencing psychotic symptoms associated with alcohol dependence. So most of them are associated with delirium. Here, again, you need to keep in mind that delirium is the far more common entity, and also it causes psychotic symptoms more. At least symptoms that seem like psychotic. So as a clinician, you need to keep that in mind. The mean age of onset of psychosis was significantly later in AIPD. That was 36.2 and 37.4 years compared to schizophrenia. Again, this was discussed in the earlier slides. The sex ratios in patients with AIPD and alcohol withdrawal delirium were similar though. Now, coming to the clinical features. Benedetti in 1952, Victor and Hope in 1958, and Johansson in 1961 all categorized alcohol-induced psychotic disorder by acute onset of auditory hallucination, which were often persecutory in clear consciousness and the absence of thought process disorder. And these used to occur in people with heavy alcohol consumption. So not just consumption is required, but heavy use is required. The hallucinations are characteristically in the form of derogatory voices. Insomnia, anxiety, depression, all can occur. So because they are independently due to alcohol use disorder. So one can discuss about the combination and various mix and match features endlessly in this area. Course and prognosis. Most studies reported a favorable prognosis, with symptoms typically clearing within weeks. Hallucinations tend to clear within 1 to 6 months. A relapsing course was reported in some patients, leading to a schizophrenia-like illness. Again, relapse is seen, not the common result. High rehospitalization rates seen in newer studies, though. So 62 to 68% people were rehospitalized over a 4 to 5 year period. It suggests a worse prognosis than previously reported. So maybe new data is warranted. Now, abstinence from alcohol usually leads to remission of AIP. This has been known since a very long time. However, hallucinations persist in some patients despite abstinence, whilst others remain relapse-free despite ongoing alcohol consumption. So see again, if you think about it, hallucinations, if they're persisting despite abstinence, then automatically the psychiatrist tends to make a diagnosis of primary psychotic disorder, right? But it not necessarily be the case, and that needs to be kept in mind. Now, coming to associations with schizophrenic illness, there are various hypotheses regarding the relationship between AIPD and paranoid schizophrenia. So basically, what they have seen is that schizophrenia develops after a person has had AIPD in a few patients. So why so? First is that the AIPD was diagnosed incorrectly, and the psychotic symptoms or the alcohol use disorder was itself secondary to the schizophrenic illness. The second was as a latent form of schizophrenia that was present since the start and was precipitated by excessive alcohol, or as a direct toxic effect of alcohol, or as a coincidental occurrence of schizophrenia in someone with alcohol. So current evidence supports that the two disorders are separate. So on the basis of demographic or on the basis of clinical grounds, we can get two very different disorders. Now coming to genetic considerations. 3 studies reported a higher incidence of alcoholism in the families of patients with alcohol hallucinosis than in the general population. Families of schizophrenia and relatives of patients with alcohol hallucinosis was found to be more common than the general population. Again, the literature is there that some association might be there, but we are not very clear. Findings from twin studies also suggest that patients with alcoholism and schizophrenia have a predisposition to each disorder separately. Several neurobiological mechanisms have also been proposed. So first one is why somebody would have hallucinations in alcoholism. So first is dopaminergic dysfunction. Second is serotonergic dysfunction, then decrease of brain inhibitory amino acid neurotransmitters, altered beta carbolin activity, involvement of essential fatty acids, possible damage to auditory or sensory pathways. Anything can be happening. The people are, the literature is also not very certain. Increased plasma glutamate and aspartate have been reported in AIP. suggesting hyperactivity of excitatory neurotransmission, which could be exacerbated by the loss of ethanol potentiated GABA inhibitory effects when the alcohol intake is discussed. So these are how they are trying to conceptualize on a neurobiological level as to what is happening. So what about neuroimaging? When people tried to see, they found that chronic alcoholism, which predisposes to psychosis and alcohol amnestic disorder, is generally associated with reduced regional blood flow, cerebral blood flow in gray and white matter areas. So most PEC studies have shown reduced frontal lobe regional flow in alcohol dependence. Heterogeneous blood flow was reported in patients with alcohol withdrawal with variability in temporal and parietal lobe cortex. Again, nothing is conclusive here, but this is what they're able to find. If you consider FDG PET data, then there was a study done, four patients and suggested a possible thalamic dysfunction. So those might also be areas that we need to explore. Glucose metabolism was reduced in both frontal and thalamic regions and cerebellum also. So these are usually the regions where the dysfunction is most prominent. So for example, chronic alcohol intake is also associated with cerebellar syndrome. So maybe it selectively is more toxic to certain areas of brain than others. We do not know as well. Now coming to treatment, what do you do? What do you try to do? At least the main essence of treatment. Patients with AIPD frequently require hospitalization because there is a risk of suicide. Antipsychotic medication is frequently recommended. No studies have compared the efficacy or tolerability. Abstinence and various antipsychotics have been associated with a favorable outcome in uncontrolled case control studies. So there are two things that we can do. Either we can give an antipsychotic or we can ask the patient to be abstinent from alcohol. Both have been shown to be effective. Superior efficacy of the inhibitory neurotransmitter glycine and of valproate were reported in only documented randomized placebo-controlled studies in AIPD to date. Anecdotal reports suggest that there is usually no need for maintenance antipsychotic treatment in abstinent patients with full remission of symptoms, although relapse prevention studies have not been conducted. So preventing is a controversial area here, and we'll not discuss much about it. It is for because that again is for another lecture. To summarize, current evidence suggests that AIPD can be clinically distinguished from alcohol withdrawal, delirium, and schizophrenia. Low prevalence of AIPD has been challenged, although there is a risk of overestimation depending on the diagnostic criteria applied. AIPD is associated with high comorbidity with other psychiatric disorders, high rehospitalization and mortality rates, and suicidal pain. Concurrent dysregulation of several neurotransmitter systems may be involved in the pathogenesis of psychosis in alcoholism, and neuroimaging studies suggest perfusion abnormalities involving occipital, frontal, temporal, parietal, thalamus, and cerebellum. Antipsychotic treatment with alcohol abstinence remains the preferred treatment for AIP. Now coming to other than alcohol, see, alcohol has been the most common substance inducing psychotic, which induces psychotic disorder because of the high prevalence of alcohol itself. But there are various other substances which are also notorious and common. So here we'll just go through a few substances, at least the names. So we have cannabinoids, synthetic cannabinoids, all of them can be causing problem. So cannabis-induced psychotic disorder is actually fairly common. Then we have catenones, cocaine, methamphetamines, all of them a little bit of a stimulant effect. Hallucinogens independently causes hallucinations and then can induce a psychotic disorder, whereby even when the substance is stopped, the activity is not stopped. If you can see, all of them will have different pathways. So some will act on CB1 receptor like the cannabinoids. The hallucinogens will increase the 5-HT concentration. Methamphetamines will increase the DA concentration, right? Now here, two other things. Entactogens and phenylcyclidine and ketamine-induced psychosis need to be kept in mind. Entactogens increase 5-HT concentration through inhibition of SERT by reversing SERT-NA concentration. It also acts on NET, DAT, all of those things also. So basically all of the neurotransmitters are getting affected. Phenylcyclidine and ketamine are NMDA receptor agonists. They act on D2, causes massive release of D2, and finally what happens is you get this problem psychosis. Now, coming to cannabis induced, right? It is also a very common disorder. Cannabis also in itself is most widely used illicit substance in the world. Alcohol, remember, is not illicit. Uh, with 6 to 7% of population in Europe and 15.3 in USA using cannabis each year. The lifetime use of this substance can reach up to 27% in European population. Content of THC is what matters here. So content level of THC is directly proportional to the psychotic symptom. Interestingly, since 2009, the power of cannabis has increased while the price has remained the same. Therefore, defining the real incidence and prevalence of psychotic disorders following cannabis use is not easy. But whatever data we have, studies show a range of 0.87 to 10.60%. Now coming to pharmacodynamics and toxicology, again, delta 9 THC, partial agonist on cannabinoid receptor 1, widely expressed in the CNS. CB2 is mostly expressed on peripheral terminals and not in the CNS. But basically, that is where it is going to act, right? So THC is responsible for cannabis adverse effects such as cognitive deficit, psychotic, and anxiogenic effects. The psychoactive effects of THC include psychotic symptoms such as paranoia and hallucination, negative symptoms, feeling of disinhibition or dreaminess, sensations of heightened awareness of music, sounds, and colors or tastes. Acute episodes of cannabis-induced psychosis can last few days to months, with a duration that varies consistently across studies. So different studies have found different things. We are not sure. Interesting to note here is the presence of cannabidiol, the second most prevalent cannabinoid in the common cannabis, which does not seem to induce psychotic symptoms, yet somehow exerts anti-anxiety, that is anxiolytic and antipsychotic. So Morgan et al. Administered cannabinoids by inhalation to 48 cannabis users. They found an increase in psychotomimetic symptoms following administration of THC alone and combination of THC and CBD, especially negative perceptual distortion and cognitive disorganization. Similar findings were reported by Clean Lou in randomized placebo-controlled clinical trials on male mild cannabis use. Specifically, transient psychotic symptoms were seen after THC administration as measured by the positive and negative symptom scale. Now, coming to the neurobiological underpinnings here. So, most common hypothesis involves an imbalance in dopamine in the prefrontal cortex. Usually, when psychosis is concerned, something needs to go, some problem needs to happen with dopamine. That is more often than not the So, Bhattacharya et al. Showed that psychotogenic effects of cannabis were moderated by two genes that influence dopamine metabolism. Similarly, polymorphisms in the COM gene seem to moderate the psychosis-inducing effects of cannabinoid. Brain imaging SPECT studies showed that THC did not lead to a significant increase in dopamine release, even though the dose was sufficient for participants to experience psychotic symptoms, suggesting a non-central role for striatal DA in THC-elicited psychosis. So it is not very clear, but something is going awry with the DA mechanism. Radhakrishnan et al. Tested the hypothesis that inducing a GABA deficit in healthy subjects might increase cannabis psychotomimetic properties. So, pre-treatment with iomazenil, an antagonist of benzodiazepine, followed by THC administration, induces significantly more severe psychotic episode when compared to THC alone. So, other neurotransmitters also seem to modulate the situation, especially GABA. So, if GABA is not there, then the predisposition to psychotic episode is there. So now detrimental effect of cannabis abuse on the psychotic. Longitudinal study carried out by Henri Garcia et al. Found that cannabis is a risk factor for the development of schizophrenia in a cohort of 50,000 Swedish men with a history of cannabis use in late adolescence. A study that followed up 705 subjects for 6 to 60 months showed that cessation of cannabis use may be beneficial in terms of reducing the psychotic experiences and subsequent risk of psychiatric disturbance. So basically other studies carried out by Valmagia and other people, the results basically showed that lifetime frequent early onset and continued use were all associated with the more probable transition to psychosis. This is corroborated by brain functional imaging study, which showed that repeated exposure to cannabis during adolescence may have detrimental effects on brain resting functional connectivity, intelligence, and cognitive function. According to literature, cannabis seems to have acute psychogenic effects, as we have been discussing. And longitudinal studies also show that cannabis can increase the risk of developing psychosis, especially in subjects already at risk for psychiatric disorders. Cannabis seems to have the highest conversion rate to schizophrenia compared to other substance-induced psychotic disorders. So this is again an interesting relation, which has been long discussed in psychiatry, but no conclusive things have been found. Symptoms of presentation might have a predictive role for the consequent psychiatric disorder. So in a recent study, half the patients who developed non-affective psychosis progressed to an independent psychotic disorder, while only 7.7% of people who developed predominantly affective psychosis developed an independent disorder. So again, non-affective psychosis, right? Primary negative symptom, cognitive disturbance, thought disturbances, basically. So formal thought disorder, things like that, more predisposed to, or more point towards a primary psychiatric health. Now, coming to synthetic cannabinoids, okay, so there are various synthetic cannabinoids, Spice, K2, JWH018, Kush. Illicit narcotic substances commonly abused in USA, Europe, Australia. Basically, SCs are not, first of all, SCs are not detected by common drugs. THC is a partial agonist, right? It does not have full agonist activity. SCs are full agonists. So it has a higher affinity than, also binding affinity is higher than a delta 9 THC. So a full-blown effect, right? And if we, as previously discussed, we are trying to correlate the strength of the THC with the psychotic symptoms, right? So imagine this is a super strong agonist. So now it generally, intuitively, you can think about how the incidence of psychotic symptoms will be more here. Now, coming to case reports, they show transient acute psychotic symptoms such as paranoia, visual and auditory hallucinations after smoking K2 or Spice. Case reports also are there about visual hallucinations after a single dose of JWH018, which is a synthetic cannabis. So there are case reports, but no well-made studies. Now coming to the next category, stimulants, psychostimulants, or as they're called, misused by youth, taken at a higher dose than prescribed usually. There are various techniques, crushing, insufflating, many things. 1.8% of youth aged 12 to 17 misuse prescription stimulants. The number jumped to 7.5 when the age group of 18 to 25 was concerned. So the stimulants have a very unique profile. Okay, there is a dose-response relationship. More the dose, higher the symptoms of psychosis. Now coming to the first one, amphetamines can result in acute psychosis. Healthy individuals in laboratory settings begin to experience symptoms of psychosis at doses between 100 and 300. Between 8 to 46% of people who regularly misuse amphetamines experience a substance-induced psychotic episode, and binge pattern of use may increase the likelihood of psychosis. Now, how will this present? Again, there are only subtle differences. There is no clear-cut change in the picture, but this one is more similar to schizophrenia, like disorganized thought, impaired concentration, delusional belief, often persecutory. Hyperactivity is also there because this is a stimulant. So the overall restlessness increases. Now coming to methamphetamine. Transient psychosis is one of the best documented effects of heavy methamphetamine use. So common clinical characteristics, methamphetamine associated psychosis, again, persecutory delusion, visual hallucination, hostility, anxiety, depression, cognitive disorganization, and hyperactivity. Similar to the previous there is inconsistent evidence whether negative symptoms of psychosis are associated with this phenomena or not. Again, I although did mention that negative symptoms is more point towards a primary psychotic illness, but negative symptoms, if they occur in substance-induced psychotic disorder, the data is very poor regarding whether it is connected to a primary one or not, primary psychotic disorder or not. Here, the risk of psychosis seems to be higher with increased drug potency and frequency of use in the case of amphetamine, whereby in cannabis, it was more related to drug potency. Now, the main stimulant, the drug of abuse, cocaine, coke, stimulant, recreational drug, erythroxylon coca plant, derived from erythroxylon coca, packed with plenty of alkaloids. One of them is cocaine. Okay. So cocaine use is associated with various disorders, not only psychosis. But its consumption may lead to both transient psychotic symptoms and a complete induced psychosis. Cocaine has been demonstrated to bind at the DAT receptor. DAT is again a dopamine DAT transporter, dopamine transporter. Again, dopamine system is being affected. On the outward facing conformation, blocking in this conformation. In addition, cocaine also acts as an inhibitor of serotonin and noradrenaline reuptake. So both of these will also. So basically, it is a full-blown monoamine reuptake inhibitor, right? Increasing levels of everything. Cocaine has also been shown to antagonize the 5-HT3 receptor, but that effects are still unclear. But what is it causing? Cocaine also blocks sodium channels, interfering with the propagation of action potential, and hence local anesthetic. Clinical characteristics, right? So various studies were done. So psychotic features in cocaine use is very common, from 29 to 86% in certain studies. In a study on 55 patients with cocaine addiction, 29 reported psychotic symptoms. 90% subjects had a paranoid delusion. 96% experienced hallucinations. Most common were auditory, and 29% developed behavioral abnormality. So, in a larger European study, higher frequency of paranoid and suspiciousness beliefs was seen. Hallucinations are also seen. The quantity of cocaine consumed is positively related to the onset of psychosis, with a significant correlation between dose and severity. Additionally, using cocaine at a young age leads to a higher vulnerability. So there are studies also, if you start cocaine early, then the chances of developing psychotic disorder are more, which might indicate that the dopaminergic system is a little vulnerable at an early age, and we should not be messing with it. Psychiatric comorbidities were proven to be a risk factor, especially regarding ADHD. Previous of psychotic episodes and various personality disorders, among which the most common are antisocial and borderline. Now coming to hallucinogen-induced psychosis. As you can see that I've put a question mark there, so we'll discuss why. The term hallucinogen was introduced in 1954 by Hoffer. The more recent term is psychedelic, literally meaning mind manifesting, has also been employed in the scientific community to underline the fact that psychological state induced by the hallucinogens is not necessarily defined by pathological symptoms. Classic hallucinogens are considered such substances as those with a psychopharmacologic profile resembling one of mescaline, psilocybin, or LSD. Pharmacodynamics and toxicology, there are two main chemical classes of classic hallucinogens: tryptamines, phenylethylamines. Tryptamines include TMT, that is dimethyltryptamine, psilocybin, which is 4-phosphoryloxy-DMT, and lysergic acid, diethylamide. This class of drug exerts its main effect on increasing 5-HT brain level through agonist or partial agonist activity on 5-HT receptor. And as it messes with the serotonin system, compounds like psilocybin have been are under evaluation for their antidepressant activity also. 5-HT2A receptor seems to be the most important hallucinogenic target. So 2A, remember that. Results in the reduction of inhibitory activity by the thalamic reticular nuclei, the altered firing of raphe nuclei, and the augmented activity of locus coeruleus. Coming to epidemiology, Wallersness et al. Found a prevalence of psychosis of 20.9% for LSD and 18.8% for psilocybin mushroom between recreational drug users presenting themselves in an emergency department. So relatively high numbers. These results, but should be examined in the light of important limitations, and that there is no previous psychiatric diagnosis collected or no follow-up data. Diagnosis was made by an ED clinician, that is emergency department clinician, and not a psychiatrist. So when there was a search done since 2003 for case reports, LSD-induced psychosis was only found in 3 case reports. So there is conflicting data, right? One study will suggest that there is a relatively high percentage. Then if you go and find reports, you will not get any reports. So something is wrong, something is not clear. Dos Santos et al. Found that psychotic episodes are associated with ayahuasca, a natural hallucinogen, and DMT intake described in 8 case series case report examined were associated with several contributing factors and not only ayahuasca or DMT intake. So Dos Santos says that psychotic episodes, if occurring in the context of an hallucinogen, might have some other predisposing or contributing factors and might not just be due to those things. Again, the literature is so scarce that it is hard to make any conclusive remark or statements. So now coming to the altered state of consciousness, a term coined by Ludwig. So basically that is what these drugs induce: sensory alteration, affective, particularly visual perception. They affect the perception, visual perception, but also auditory and tactile, audiovisual synesthesia, and altered experience of time. So this is the state that these substances put you in. Perception changes represent the most characteristic symptoms and include alteration in the perception of shape, size, color, and the illusion of movement, but also more complex scenes, right? So people, if you go on the internet and see people describe their experience after using DMT, ayahuasca, or any other thing, any hallucinogen, they will give very vivid description about how and what they experience, right? It is very interesting to listen to those people. So anybody who's interested in descriptions can go on the net and find them. Anyway, alterations of visual perceptions infrequently only represent true hallucinations, since they can be distinguished from real perception, at least at moderate dose. So, Leakey et al. Recently reviewed the controlled clinical studies of LSD published in the past 25 years, focusing on psychotic symptoms. He found that LSD use was not characterized by unpleasant psychosis-like symptoms, but instead by an overall positive mood state in the greater part of subjects. Krebs and Johnson reported that there was no significant association with the lifetime use of psychedelics and increased rate of any mental health outcome. Dakar et al. Also said that no cases of prolonged psychosis or hallucinogen persisting perception disorder have been reported in modern trials with psilocybin, ayahuasca, or LSD. So there is a lot of literature saying that hallucinogens are not causing psychotic symptoms, at least not in the long term. So only time will make it more clear when we get more and more data. So now these were the main substances that are concerned, but there are other substances that are documented to cause psychosis also, but the literature for them is relatively more poor. So the substances discussed before, believe it or not, but they are the ones with the stronger literature, even though they are still not conclusive in many cases. But these have very weak cases, but reports of psychosis or case studies or certain trials have been done and they found. So fluoroquinolones have been linked to a serious case of toxic psychosis. Mefloquine has been associated with psychosis. When you consider over-the-counter drugs, dextromethorphan at high doses, so people ingesting or abusing cough syrup, certain antihistamines at high dose, maybe they push the patient into delirium. We are not sure because we do not have clear-cut data. Cold medications, which contain phenylpropanolamine or PPI. Prescription drugs, including prednisone and corticosteroids, isotretinoin, anticholinergic drugs, atropine, scopolamine. Again, anticholinergic drugs predisposed to delirium. So, are the psychotic episodes described in such case reports or in the weak data actually psychotic episodes or just episodes of delirium? That is also antidepressants, L-dopa, anti-epileptics, anything can cause. Antimalarials, mepacrene, can also cause psychosis. There have been reports. When you think about plants, you think about Hawaiian baby woodrow, morning glory seed, Jimson weed, belladonna. All of these can cause psychotic symptoms. In non-medicinal substances, carbon monoxide, carbon dioxide, carbon disulfide, heavy metal poisoning, organophosphate, insecticide, sarin and other nerve gases, aniline, acetone and other ketones, antifreeze, which is a mixture of ethylene glycol and other glycols, arsenic and its compound. So it's not necessary for a person to have psychosis in relation to a certain substance. There is a wide array of substances in which there have been reports regarding psychosis. right? So somebody who comes with heavy metal poisoning and having psychosis might be due to that. It's just the clinical suspicion and the clinical, just the suspicion and knowing the possibility that this can happen is enough. So now coming to antipsychotic induced dopamine supersensitivity psychosis. All currently used antipsychotics interact with the D2 receptor due to dopamine mediated signaling. Long-term administration of antipsychotics can increase brain dopamine binding site and produce behavioral supersensitivity. In humans, this behavioral supersensitivity to dopamine can be expressed through supersensitivity psychosis and movement disorders such as tardive dyskinesia. So in this type of psychosis, new or re-emergent psychotic symptoms develop, generally appear accompanied by dyskinetic movement. Again, the TD or the tardive dyskinesia in itself is explained by supersensitivity, right? So supersensitivity is not only in the motor system, but also in the mesolimbic system, whereby it is causing supersensitivity psychosis. It is most closely associated with schizophrenia and use of typical antipsychotic agents. It has also been documented in patients with other diagnoses and those receiving atypical antipsychotics. So it is not limited to first generation antipsychotics. Basically, it is related to dopamine block. Also, another thing to note is that there is no established treatment for this condition, but many drugs and treatments have been tried over the years. In the eras of FGA, the first drug treatment given for supersensitivity psychosis consisted of adjuvant anti-seizure drugs to antipsychotics. Clozapine, ECT were also a relevant treatment for supersensitivity psychosis. Asenapine is an alternative treatment for SP. It is an SGA with partial agonistic properties at 5-HT1A and potent anti-5-HT2 activity relative to anti-D2. Once SP has developed, SGAs with long T half-life, such as LA injectable antipsychotics, which have continuous blockade of D2 receptors, should stabilize blockade of D2 receptors within optimal therapeutic ranges and minimize fluctuations and above and below therapeutic. For example, LA acting risperidone can do that. So, in supersensitivity psychosis, you need to consider LA injectable psychosis. Now, coming to management of substance-induced, if a young person is prescribed a medication that may have contributed to substance-induced psychosis, then this medication should be stopped. A young person with SIP has occurring substance use disorder. Medication to treat the SUD should be discussed with the patient family. Antipsychotic medication is initiated for individuals with symptoms of psychosis that persist when they are not acutely intoxicated or withdrawing from the substances, or individuals who are not able to establish periods of abstinence. When prescribing antipsychotic medications to individuals with SIP who also smoke tobacco regularly, clinicians should remember that smoking tobacco increases the cytochrome enzyme activity. So CYP1A2 activity is affected by the products of tobacco smoke and not nicotine. Psychosocial interventions, and what do you do otherwise? Different approaches have been developed for treatment of patients with an SUD and a psychotic disorder. One approach is referred to as parallel treatment, whereby simultaneous treatment of both disorders, but by different agencies or providers, is given. An alternative approach is sequential treatment, in which the patient receives either a psychosis-focused or substance use-focused treatment in isolation, and then based on the idea that resolving one problem allows for the other to be more effectively treated. Exploring ambivalence about substance use, the pros and cons of substance, how use affects an individual's life goals, potential long-term risks, and all is the key to exploring the drivers of behavior, basically. So proper anti-addiction of a proper treatment psychotherapy for addiction based pathology, or maybe proper treatment for understanding or raising the insight with relation to the psychotic symptoms might be needed. CBT for psychosis, again, so same thing. CBT provides a theoretical model that is accessible for patient for explaining the distal and proximal triggers to their psychotic thinking pattern. So how to understand the links between thoughts, feeling, behaviors as they underpin and potentially perpetuate hallucinations and delusions. CBT for psychosis and SUD is designed to teach skills in managing stress, managing unhelpful and unrealistic thinking patterns and behaviors, and to challenge cognitions that might support ongoing substance. Other evidence-based treatment in addressing youth substance use, such as the adolescent community reinforcement approach, can complement MICBT by enhancing motivation to engage in competing activities that do not involve substance use, improve communication and problem solving, and increase parental bonds. So, coming to the summary, finally, what have we gathered after this lecture or after the entire long term? So, literature is scarce regarding substance-induced psychotic disorder. Data regarding specific substances and data regarding the newer substances induced, which have been brought to the market is even scarcer. So we do not know much. Newer agents and synthetic compounds pose risk for users and current understanding in the areas. More data regarding specific target groups like adolescents is needed. Various agents are associated with certain characteristic symptoms that have been well documented. So we can basically at least try to guess whether this is due to that or not, but it is just still guesswork. We cannot be sure. Psychotherapy plays an important role here. So pharmacotherapy is important, but psychotherapy in itself plays a major role. But they need defined guidelines. So currently there are no guidelines regarding this. Integrated approach is currently seems to be the best method to address the often comorbid substance use disorder. So thank you. Hopefully it was informative, and that will be all.